conferences. So COVID is a very big part of public health now, and so we must give it due importance. So I welcome in this session the speakers and the chairpersons. I am sharing my slide. Hayamati, is my slide visible?
Yes, it is. Yes, it is.
Okay, okay, please stay. So the session is COVID pandemic, the way forward. And in this session, we have the chairperson. We have got two chairpersons. One chairperson is our dear own Sukomal sir, Dr. Sukomal Bishwai. Sukomal sir is actually an MBBS and MD in community medicine. He is currently working as a professor and MSVP in the Devan Mahato Medical College. And he has also authored numerous books on undergraduate and postgraduate community medicine. So welcome Sukomal sir to the session.
Thank you. Thank you very much.
Our next chairperson is our dear Professor Paramita Sengupta Madam. She is MD Community Medicine, and she is also the Dean of AIIMS Kolani and faculty and HOD of the same institute. She has been a faculty for more than 20 years and fellow of IPSM and IPHA. She is a life member of IEA, WNCD, and has been a PI of numerous ICMR projects. She was a national assessor of effective vaccine management and published 50 papers in index journals. So welcome Paramita Madam to the session.
Thank you, dear Review, and good evening to everyone.
Good evening. Our next speaker is Professor Kunal Kanti Mojumdar. She is a professor, DMCW, DPH and MD Community Medicine. And he has been training many courses like MSc and PhD and has been examiners in various universities. He has got numerous publications and has worked on several projects on public health, mostly on asyncosis. So welcome Professor Kunal Kanti Mojumdar. And our last speaker, thank you sir for joining from halfway around the globe. Sir is Jean-Frederic Levesque. He is an adjunct professor at the Center of Primary Healthcare and Equity at the University of New South Wales and Chief Executive of the Agency of Clinical Innovation in New South Wales, Australia. He is a public health and preventive medicine specialist and has got a PhD in public health from University of Montreal. He has got a long experience in research and policy setting on the use of new models of care, and he recognized as a leader in health service researches. He has got numerous publications and with an H index of 28. And his research and theory on access to healthcare has been critical, informing both other research and policy, with his paper on the access model being cited more than 1,000 times. So he is also from community medicine or community health from around the world. So he's one of our fraternity only. So welcome, Dr. Jean-Frederic Levesque.
Good morning, or good afternoon, should I say?
It is good evening here, sir. Okay. So now I hand over the session to our chairpersons. Professor Paramita Sengupta, if you can please start the session.
Hello.
Yes, madam, you are audible.
Hello.
Yes, you are audible, madam.
Yes, yes. May I please invite the first speaker to present his session?
Okay. So, sir, Jean-Frederic Levesque, sir,
Dr.
please.
Kunal Kanti Mojumdar.
Sir will be presenting first. Dr. Jean-Frederic Levesque, kindly
Okay.
present. I am stopping my screen sharing. Sir, you can present now. Kunal sir will be next.
Okay, so I don't have slides. I'm going to speak just without slides. And of course, I'll pay attention to questions if there are any. And thank you. Thank you for the invitation to talk today. So just a bit more about me. As Rivu kindly introduced me, I'm a medical doctor with a specialization in public health and a PhD in public health as well. And really, I try to blend medical, public health systems and economic perspective in my work, and I'll talk a bit about that today. I was born in Canada. I'm French Canadian by background. I do live in Australia now, but I also have strong ties with India, having worked in the Nilgiri and Tamil Nadu region of Tamil Nadu. And also I conducted my PhD in co-supervision with Dina Narayana from the Center for Development Studies in Thiruvananthapuram in Kerala. So I have many collaborations with Indian researchers, and it's a real pleasure for me to join your conference today and share some thoughts about the pandemic. In Australia, my role, as was said, is to lead the innovation agency in New South Wales, but also during the COVID pandemic, I established a COVID-19 critical intelligence unit. And this unit had for mandate to support decision-making of governments and also lead the scientific evidence and data intelligence activities in the state. So I will share some of the insights that really came out of this role as part of the New South Wales health system. So what I wanted to cover in the next few minutes are some reflections on the pandemic, talk about the Australian context, which is obviously the one that I know more about and want to share some insights with you. Talk about the public health response and the key activities that we engaged in during the pandemic, and some challenges also to public health that emerged out of it. And if I can raise some issues that relate to equity in health that are generated by the pandemic, I'll just finish with this. So you all know that the SARS-CoV-2 pandemic is really a worldwide crisis. There's no question. We don't have to establish that fact anymore, having lived almost 2 years now with the virus and having to respond to it. Let's say that it's been characterized by a context of uncertainty, and the latest issues surrounding the emergence of the Omicron variant again is throwing us all in a context of uncertainty. And from the perspective of responding as much as possible based on the scientific evidence with regards to public health, this of course has been a very challenging time, with the evidence evolving very quickly, and the challenges in combining traditional public health responses with modern public health responses challenged all the time as well. So some key aspects of the pandemic that we all had to face were the rapidity of spread due to highly mobile populations and really integrated economies compared to previous pandemics, the rapid communication and social media that also provided both opportunities for public health messaging as well as challenges in terms of miscommunication. The very rapid technological developments were amazing, with genomic testing, therapeutics and vaccines appearing very quickly. Only in a few days, the virus was completely sequenced, again, providing tools for public health that were very different from what we had done in previous outbreaks and previous pandemics, and very different already from SARS-CoV-1 just a few years before. And one of the key aspects also that was both an advantage and a challenge was certainly the integrated supply chain for many health and medical products, really demonstrating that countries were dependent on each other for production of personal protective equipment, for example, for healthcare settings, and of course many products of daily life, which now we can see are challenged by the ongoing pandemic. And one of the factor that we need to consider in all of this as well is the very high level of economic inequalities around the world between and within countries. And these underpin the pandemic behavior as well as the impact of the public health response. So in Australia, we have experienced 4 waves of the pandemic. However, the first 3 were really limited clusters, especially from the New South Wales perspective. We had first, of course, an outbreak that emerged like everyone else in March, April. It was driven by traveling and incoming travelers for us. Then in July 2020, we had a outbreak due to our hotel quarantine system. And in December and January 2021, we potentially had a pilot, an airplane pilot introducing an outbreak. And then from July till now, we really have the first significant epidemic in Australia in New South Wales, which is the Delta outbreak. And it started again from hotel quarantine and has really spread through pockets of poverty, pockets of social disadvantage, and is now really establishing itself as an endemic at the endemic stage within our state. So it's really as of last July only, so for the last 5 to 6 months that we really faced COVID-19 in Australia. As you know, before that, we were having a very isolationist and elimination strategy to the virus. And now we have to learn to live with the virus. In terms of our response, up until now, really, the public health response in Australia has been characterized by first border closures, and that is now gradually changing with international travel being gradually reintroduced, and also the mandatory 14-day quarantine in supervised hotels was the mainstay of our approach, and this has also been abolished very, very recently. But up until recently, this is how we managed the pandemic. We had very, very high levels of testing. Contact tracing and isolation was ramped up. There was training of public health teams so that we would increase our capacity to contact trace and ask people to isolate as much as possible. We had physical and social distancing orders in place with a lot of restrictions on the New South Wales population. We closed schools and forced people to work remotely and really closed all non-essential commercial activities for many months in our context. Our approach was similar to New Zealand when you think about it. We had the very limited curfews, however, and limited stay-at-home orders. We used other means to control the pandemic. Of course, the wearing of masks in public places, and at times even outdoors, was established and ramped up or down depending on where we were in the pandemic. And in terms of impact on healthcare, we stopped all elective surgery for many months, and we also had a very strong monitoring and reporting of data, which of course was part of my role in the New South Wales context. And of course, since the introduction of the vaccine, this has become the mainstay of the public health response. So you can see that in our context, we really try to mix different approaches to control the pandemic. And that has really enabled us to successfully control previous outbreaks and now take the current situation to a fairly low level with around 60 cases per million on a daily basis at the moment in New South Wales, which is still a very low rate in comparison internationally. There has been some challenges that I wanted to share with you because, you know, as a group of public health specialists, you share with me the background of training in public health with, you know, classic measures and classic ways to look at and understand epidemic of an infectious disease like COVID-19. And really, public health has been a challenge for us for various reasons. First, it was a very different context compared to previous pandemics, as I alluded to before. And the usual infectious disease control issues that we had to deal with were very different. Before that, we had smaller scale epidemics or outbreaks. It was affecting subpopulations only. We knew the pathogen and we knew the behavior of the pathogen. Previous outbreaks very often had a limited economic impacts, not a nil economic impacts, but a limited economic impact. And regular public health laws and processes were sufficient to control other types of outbreak. But this is a new pathogen and there was lots of uncertainty around it. So we had to establish a public health response at the same time as we were gathering evidence about what would work, which is of course very challenging. Worldwide, the issues of mobilizing all public health resources more and more pose challenges in terms of managing, protective equipment, for example, and supply of various therapeutics. We ended up in a situation where countries had to collaborate on many aspects, but also at the same time had to compete on many aspects to obtain the right equipment, for example, to respond to the pandemic. And everybody facing an outbreak and a significant epidemic all at the same time across the world really illustrated the need for very strong centralized bodies to continue to be there and play a role in coordinating responses. The impact on population was massive, as you know, and when public health measures were successful at reducing case numbers, there was a paradox of public health facing a situation where we could actually create more harm than good through the actual impacts of the COVID measures. So if COVID measures were significantly impacting on economic activity, for example, people could lose their jobs, end up in poverty. And of course, from a public health perspective, we all know that this has impact on nutrition, development of children, etc. So public health really had to constantly balance responding to the pandemic so that we would control the number of cases and prevent healthcare systems to be overwhelmed by people requiring respiratory support. And at the same time, the impact of our measures having an impact on the economy and on other social determinants of health. And of course, with some negative impacts on the health of the population. Constantly balancing those has not been easy in the Australian context, nor of course in India or other countries. So this pandemic has not only affected individuals from an economic perspective, it has impacted entire country economies, with big businesses and broad groups within societies being very strongly impacted as well. It has made the role of the chief health officer one of the most politicized role in a context of misinformation, conspiracy theories, and very personal, and at times, unfortunately, personalized abuse through social medias as well. And we all know that views have been very polarized in our response to the pandemic. So I just wanted to finish this quick address by raising some equity issues that we had to face, and maybe use these as a way to also generate a conversation with you today. As I mentioned at the start, inequity had played an important role in this pandemic. Lower socioeconomic status populations were more vulnerable to the infection firsthand. Those that were working in industries where social proximity and public-facing roles were important were at high risk in these workplaces. Those with bigger families and those that were living with chronic diseases and comorbidities were more at risk as well. And lower socioeconomic status also affected the way people were actually impacted by the consequences of the pandemic and the public health response. They had more infections and mortality, as I said, but also less access to healthcare, less work and capacity to study from home, and therefore people from low socioeconomic status ended up both exposed to the actual infection as well as to the consequences of being infected or being affected by public health. And of course, more recently, we could see that poorer populations also had lower vaccination rates and ended up with another form of disadvantage through the pandemic. So one of the things that we had to do in our context, and I really think that it's going to be something that will affect the way we have to respond to the pandemic in the future in many different countries, is that we had to shift to a whole population approach, which adopted a micro strategy, a very localized strategy to go alongside the population-based and country and statewide strategies. The statewide orders that we imposed really had restrictions both on low risk, on people at low risk of infection, and when we impose those restrictions on the entire population, including those at low risk, it usually impacts unequally the poorest, and we had to change that. So the micro strategy that we developed was first to really develop a good monitoring system to better understand the local outbreaks and the social drivers of the outbreaks. Were these outbreaks generated by specific work environments? Was it driven by specific school settings or specific community and populations that needed to be engaged with in a more direct fashion? The second aspect was that we had to engage with local communities to reach the harder to reach, really engage with community leaders for our communication efforts, and not just rely on overarching messages in the population, but instead go to strategies that were more mouth to mouth, people exchanging through their own social network and connections to provide information about the outbreak and about the appropriate behaviors to try to control the pandemic. We had to third target protective efforts towards the most vulnerable. And that included providing food support and providing social support so that people that were infected but couldn't afford to go without work, for example, could be supported in isolating and prevent the transmission to other loved ones, for example. So, one example of that targeted protective effort that we did was to provide support to older people so that younger males that very often were in charge of providing assistance to these older people in the evening after work could actually, be supported in doing so and prevent spread to older people as well. We had to provide social assistance to make it possible for these communities to comply with public health orders, because we quickly realized that the ones that we were trying to target in terms of changing their behaviors so that we would slow the transmission of the infection were actually those that were absolutely in no position to be able to change their behaviors in a safe way for them and their family, and therefore they couldn't comply. And we had to communicate in a more targeted way as well, translating a lot of the products that we had created to respond to the pandemic and provide an approach which was much more respectful of local communities. That didn't mean that we didn't have all of these other public health measures, social distancing, at times imposing curfews and things like that, but we had to complement it with an approach which was much more at the local scale, really reaching out to specific communities. So I just want to now finish with just a few thoughts that I think we need to consider in our response. And I can see some questions are emerging, and I'll be guided by the chair about the best way to move forward. But there are still significant challenges that we will face as this pandemic continues to unfold. And the first one is to realize that there is a discrepancy between those that benefit from a health perspective and those who suffer at times from an economic and a social determinant perspective in our response to the pandemic. And striking the right balance between the two is a very hard task. We cannot pursue an elimination strategy. And I know that Australia and New Zealand were amongst the only countries pursuing these strategies, with Singapore potentially and Japan at some point. We really have to find the right balance. And this is really truly a public health conundrum. Very often in public health, we face a situation where there is a risk to population. There are ways we can try to address that risk, but these ways to address the risk also have some form of risk in themselves, and we need to balance them. There's never a perfect correlation with regards to the economic benefits and the health risks. And now we face a situation where societies need to go back to normalcy as much as possible. We need to have economic activities so that our population can feed themselves and continue to live. And now really balance what are the best public health strategies that will avoid too many broader socioeconomic impacts on the population, trying to prevent some of the downside of our public health response. And this pandemic has really created an urgency, which is to what we need to do is to also find a way to bring back social debate and social discourse so that our public health response can be better informed by population population desire. If we are to live for many more months or years with a fluctuating situation like this, where we have to provide public health measures to support the population, we also need to find ways to hear from these different communities about what's acceptable and what are the key impacts on them of our public health measures. So I hope that this provided some insights about our context and the way we have progressed the public health response. And I hope that it will contribute to your discussions today. So, Chair, thank you.
Thank you so much, Professor Zain, for a very excellent presentation. So actually, like you said, building up an effective surveillance system is the key, and community networking and community mobilization, and as well as good communication. So along with that, question, I think there are two. Would you like to answer this? I think you can see those, or should I say?
I can see the questions.
One question is, sir, in your region, did you encounter people who were not willing to get vaccinated due to several reasons? And if yes, how did the public experts handle the problem?
Yes, of course, we did find a segment of the population that didn't want to get vaccinated. One of the things that we did is that we did specific surveys to understand within different age groups, different gender, different specific cultural communities, what were the obstacles and the barriers to vaccination that they were raising. So we found out very quickly that young males from certain communities were not willing to get vaccinated. At times it was because of wrong views around some of the potential impacts of the vaccine. There's been a lot of misinformation around impact on fertility, for example, or the genetic impact of mRNA vaccines, etc. So what we did is, of course, we had big, broad communication campaigns on TV, etc., for the general population, but we also engaged with community leaders so that they would become the relay of the information instead of the public health specialist. So we found some, we even found some cricket players, for example, to talk about the benefit of vaccination and the fact that they would get vaccinated to try to connect with some of the younger males from specific communities within Sydney, for example. So we really tried to target our approach, and we work very closely with an organization called Multicultural New South Wales. It's an organization that works with a lot of the community organizations, and we went this way. And another thing that we did is that we established vaccination centers very often in the community centers that relate to these specific communities, so that people could recognize themselves in the approach, and it would not just be seen as a big government kind of perspective. So that's how we did it. It's a lot of work because it's not as efficient as just establishing a big vaccination center, but it's certainly a method that enabled us to bring up the vaccination rate as much as we could.
So taking it near the doorsteps of the people.
Yes, exactly.
Madam, should we allow the second speaker? Then we can take the questions.
Okay, fine.
Professor Kunal Kanti Majumdar, please start your presentation, sir. We shall take the questions next after the presentation. Professor Kunal Kanti Majumdar, please. Professor Kunal Kanti Majumdar, are you there?
Professor Kunal sir, are you in the line?
You may call him and find out.
Yes.
I could take another question if you want, whilst we give the time to the
Yes,
professor.
please take another question then. Yes.
What would be our strategy to tackle pandemic situation when large number of people does not want to use face masks or does not follow COVID appropriate behavior, and there is lack of legislation? So that is the question, sir.
Yeah, that's a very difficult one, of course. Individual behaviors are driven by beliefs and risk perception. So I think that the surveillance and monitoring of the situation, but also communication of various numbers and various aspects of the pandemic is important. Mobilizing community leaders, as I said, is also very important. And emphasizing the multiple layers of protection that are required, I think, are also ways to try to tackle some of the difficult subgroups that do not comply with orders. Of course, if you can rely on legislation and you can rely on enforcement, it's one way, but it's very difficult. Even in our context, we had at some point to establish curfews. We had to give fines to people, financial, penalties to people that were not respecting some of the orders. All of this is dependent on the police capacity to actually conduct the surveillance and, give those. I would say that the most efficient strategies is to actually not necessarily try to enforce with everyone a very legal or law-based approach, but do it with some people and then make it very public that some people are receiving fines or have to respond to the police if they're not following the orders, and combine it with a much more proactive and positive approach where you offer people support to behave the right way as much as possible. Mask wearing has, of course, been a very contentious issue all through the pandemic. And it's gradually that people get to see this as a normal behavior. There's a lot of different determinants of this, and communicating to the population and is one way to try to do that. So I think that the professor has joined us. So.
Kunal sir, kindly share your presentation.
Yes.
Sir. It's visible, sir. Kindly open your PPT.
Yeah. So sorry, I'm a bit late. Sorry, there are some technical problems.
Yes,
That's
yes.
why-
Okay, sir. Not an issue.
Sorry, I have just thanks to the organizer and IPSM for giving me an opportunity to say something in this very auspicious platform. I must thank my previous learned speaker. He has given an idea about the COVID problem. I will just highlight about the Indian scenario. We all know that it's the current pandemic is going on. It has started from.
Sir, please share your screen. You have shared the wrong screen. That is not visible. Please share the PowerPoint.
Yes, I have shared the PowerPoint. Na? You are
Okay.
sharing.
Please stop sharing and then share screen and then go to share entire screen.
Then
in the upper left corner, there is the option share entire screen.
Oh. Share entire screen. Now, is it visible?
Yes, it's visible now. Sir, please continue.
Yeah. So, just the pandemic which has started in the early part of the 2020 now, which is going on. So, what we have in India, similar things we have done. There is some problem of changing the slide, I think. Again, it has got some hang or something like that.
Right, space bar.
Oh, no, previous. So just coming to the Indian context. So we know that in India, the first case was reported in 30th January 2020 in Kerala, which was also originated from China among 3 students. And as on March 2020, cases began to increase and reached its peak in September. And 19th February 2021, Ministry of Health and Family Welfare have confirmed a total of around 1.09 million cases. And on 27 September 2021, India became the second highest number of confirmed cases in the world and third highest number of COVID deaths. So as on 29/11/2021, the Ministry of Health and Family Welfare confirmed around 3 crore cases, and where the positivity rate is around less than 1%, 2%, that is 1.98%. And but the most positive thing is that if we compare the total number of cases per million, still India has is in a better position. The number of cases per as well as deaths per million is low in India, and the outbreak had been declared epidemic in more than a dozen of states and union territories, where provisions of Epidemic Disease Act 1897 have been evoked, and educational institutions, religious, entertainment, and many commercial establishments have been shut down. Tourist visas were cancelled, and countrywide lockdown started on 25th March, and it continued up to 7th May in 4 phases, and it was followed by unlock period of 6 phases till 30th November. So, Government of India divided all the districts in 3 zones based on the spread of virus, that is green, red, and orange, with relaxation applied accordingly. And the red zone was further divided into containment zone and buffer zone. And there are some infrastructural changes. Dedicated COVID hospitals, COVID health centers, and COVID care centers were created for the management of severe, moderate, and mild illness. And Maharashtra, Delhi, Kerala, Andhra Pradesh, Karnataka, Tamil Nadu, West Bengal were some of the worst hit states in India. And we had a problem of migration of laborers, creation of panic in labor class, leading to large-scale migration from place of job to native place with families. And India launched a new app known as Arogya Setu app on 2nd April 2020 by Government of India in 11 languages, including Hindi and English. It is a local-based surveillance app to let users know whether they have any contact with infected people by smartphones. So India continued with all these thing. And these are the states depending upon the endemicity, where we maximum number of cases we got from Gujarat, Maharashtra, Tamil Nadu, etc., followed by Rajasthan, West Bengal, Uttar Pradesh, and Delhi. So a second wave of COVID-19 began in March 2021 in India, where we detected more than around 20.6 lakh cases in the first half of April 21 itself. It was more devastating than the first. And by late April, the government was reporting around 300,000 new infections and 2,000 deaths per day. And obviously, with concerns of undercounting also. And the major strain was on the healthcare system. And we had a shortage of vaccines, hospital beds, oxygen cylinders, liquid medical oxygen, and other medical supplies in many parts of the country. And the current surge of COVID-19 cases is being pushed by the homegrown mutant variant, Delta variant of SARS-CoV-2, which was found to be most infectious with rapid spread. And the WHO declared two variants, Delta and Kappa, first found in India. So after younger people, the characteristics of the second wave is that it affected more younger people as compared to the first wave. And 50% infections were among people below 45 years of age in most worst affected states. And more children got infected. And we have got some newer symptoms, which was not so prevalent in the earlier phase, that is pink eyes, loose motions, hearing impairment, rash, change in the color of nails, etc. The first wave of COVID-19 was more widespread in geographical reach, with hotspots spread all over the country. But comparatively, the second wave was more infectious, but it has been limited to fewer hotspots. Now we are preparing for the impending third wave. So I will not go into the details of this virus, everyone knows. And we have multiple variants of concern, starting from Alpha, Gamma, Beta, Delta, and the newest one is Omicron. And not many facts were known regarding the nature of this variant, whether there is more communicable. In fact, they are predicting that this newest strain is more communicable regarding the spread, but we still don't know whether it causes more severe disease or death. So still we are waiting for the results. So, and in host factors are that we all know that it affects all ages, and most commonly it affects 20 to 60 years of people, and older children, adolescents transmit the virus most effectively. And here also we have found that the main spread of infection is mainly by respiratory droplets. And we have found, although chances of transmission are there from fomites and airborne, etc., but most of the infections were airborne. And I will not go into details of the regarding the pathology and other things, because everything is known to us. And the most important thing of COVID in present Indian scenario is majority of patients were asymptomatic, especially till now more than around 20 to 30% patients were found to be asymptomatic. And the majority of the cases were mild, 81% of cases were mild, and remaining 14% have the severe disease. And we found critical disease only in 5% cases, and overall case fatality in India was around 2%. And after that, ICMR categorized the different types of cases as suspected case, then laboratory confirmed case, definition of contact, etc., high risk contact already is known. And my previous speaker has also touched something, that who are the patients who are aged, having some comorbid conditions like hypertension, diabetes, etc. They are more prone to develop complications. And regarding the tests, here also in India, the gold standard test is real-time reverse transcription polymerase chain reaction, RT-PCR. And here, rapid antigen test and serological. These are the three tests mainly we use for the screening purpose as well as for diagnostic purpose in India. And ICMR has given an algorithm for COVID-19 test we first go for rapid antigen test, and if it is found to be positive, then we should treat the patient as positive. And if it is negative, and if the patient has symptomatic symptoms like fever, cough, and sore throat,
Excuse me,
definitely-
the others please mute. The speaker is speaking something. The others please mute.
I think some of them are unmute. That is why. So there is some ICM or algorithm for the diagnostic test of COVID-19. Usually it depends upon rapid antigen test and RT-PCR. If rapid antigen test is positive, then one should treat the patient as positive, and if negative, if patient is symptomatic, we should definitely send the sample for retesting by RT-PCR. And if the individual is asymptomatic, we can repeat the test by rapid antigen test, or we can send the sample to RT-PCR. So regarding the prevention of disease, actually, besides all these COVID appropriate behaviors, the government has tried to motivate or try to create awareness among the people regarding the various COVID appropriate behaviors during the peak of the pandemic, and still continuing. And regarding that hygiene, staying at home, avoiding crowded places, washing hands, maintaining safe distance, etc. And Ministry of Health and Family Welfare has raised awareness about the recent outbreaks and taken necessary action to control COVID-19. And they have created a 24-hour, 7 days a week disease alert helpline and policy guidelines for surveillance, clinical management, and infection prevention. And India is known for its traditional medicines in the form of Ayush, like Ayurveda, Yoga, Naturopathy, Unani, Siddha, and Homeopathy. And with the outbreak of COVID-19, Ministry of Ayush has released a press note regarding advisory for coronavirus, mentioning the useful medications to improve the immunity of the individuals. And there was gross restriction of travel. India has issued revised guidelines for international travelers. And regarding specific protection, we motivate the people. We by creating awareness through mass medias as well as through network to make the people wear masks wherever it is when they go out. And regarding personal protective equipments, health workers were trained and sanitizers were available in plenty. But the most important, you can say, weapon for specific protection is COVID vaccine. And India also launched one of the world's largest vaccination drive. Vaccination for COVID is voluntary and help developing strong immune response against the disease, we know. And India launched vaccination drive on 16 January 2021. And on 21st October 2021, India crosses 100 crore 1 billion doses of vaccine. So mainly in India, 2 vaccines out of 9 candidate vaccines, 2 vaccines have been granted approval for emergency restricted use like Covishield and Covaxin. Initially, there was some confusion regarding the interval between the 2 doses. Now the experts are in opinion that the minimum interval should be 12 to 16 weeks in case of Covishield and 4 to 6 weeks in case of Covaxin. And here the contraindications, mainly allergic reactions or adverse reaction to the first dose was taken as the contraindication, especially the patients who have experienced major blood clotting in combination with low platelet count following the first dose. And other vaccines, a near future, maybe other vaccines like Pfizer, BioNTech, as well as Moderna COVID vaccine, Sputnik V, and another SARS-CoV vaccine too, maybe a vaccine which will be available in the near future. But now still we are depending upon these 2 vaccines, Covishield and Covaxin. And regarding the doses, we have at least our population is around 84% of population is already covered with a first dose of vaccine. But the coverage of second dose is a bit less, around 45 to 46%. But we are coming to that, and we are just speeding up our vaccination drive. So regarding screening, as well as we started with thermal screening of with patients with clinical manifestations prior to the entry of healthcare, especially patients who are symptomatic patients having a history of travel, having history of contact with the confirmed case, etc. And the screening was followed by isolation and appropriate treatment. And in Kerala, Defense Research and Development Organization, DRDO, developed a low-cost walk-in kiosk to collect the COVID-19 samples and named it as COVID-19 sample collection kiosk. And this facility has already, they have started piloting, and these facilities can be used for massive screening for at least in red zones, areas where need for the personal protective equipment is high, as well as prevalence is quite high. Regarding contact tracing, the India has developed Arogya Setu app, I have already told you. And there was a robust, comprehensive surveillance system at the national level also. Mainly, we have taken three things: screening, containment, and mitigation to prevent the outbreak. And we also depend on 3 T's: testing, tracing, and treatment to decrease the chances of transmission of disease, thereby to contain the pandemic. Regarding management, I will not go to the details because we have tried with so many drugs as well as some advanced gadgets, and India became self-sufficient. That was one of the, you can say, the dream of our Prime Minister, that previously we are not quite confident with all these advanced devices like ECMO, as well as in all sorts of ventilators, non-invasive and invasive ventilators, and high flow oxygen, nasal oxygenation, BiPAP, CPAP, etc. But now, even India has started preparing enough number of locally made ventilators to keep up the demand. So it is one of the reasons that we are getting self-sufficient, so that we do not depend on others during the time of extreme stress. And we have also trialed with many antiviral medicines and drugs, starting from remdesivir to now molnupiravir, oral drug, which is not started in India, but we have tested with many drugs, starting from chloroquine to treat cytokine storm. We have got excellent result with dexamethasone steroid, and also we have some good results with tocilizumab to treat cytokine storms. And we have also trialed with transferring of donated blood containing antibodies, like plasma therapy, especially for moderately to severely ill patients. But what is main purpose of my discussion today, that what is new in this pandemic, what experience we got is that no other pandemic besides this havoc, besides this disaster which the pandemic has created regarding the physical health, psychological support was very important, because individuals experience distress from quarantine, travel restrictions, side effects of treatment, and fear of infection, not only from infection, but fear from death, fear from separation of near and dear ones by isolation, quarantine, loss of jobs, insecurity. So because this disease was new to us, so there must be some fear among the people, and this fear has led to all psychological problems, starting from depression, suicidal tendency. And we have found increased amount of women and child trafficking in the villages, child abuse, child marriages, because often children are left alone when both their parents were detected positive, and often they are handled by their neighbors, by their relatives, and and some of them suffered from child abuse. There are studies, and maximum impact was that was very new in this pandemic, I should say, that is social stigmatization. And initially, social stigmatization was acute during the first wave, and we have found social isolation, deprivation, etc. among the people. And exceptionally, we got some important help from and support from the various community-based self-help groups, civil society organizations, and as well as some type of social assistance, as my learned previous speakers already told. And so we need some psychological support from peers, community health worker, counselors, and people should experience their positive experience, should share their positive experience. People, especially people who have recovered from the disease, they should share the positive experience with the other people to create confidence. And stress has been given to yoga, meditation for maintaining physical distance. And Another thing we have learned from this pandemic, that we have learned self-health monitoring at home. Now, each and every family, they have got pulse oximeter in their home. They can monitor their health by checking their oxygen saturation, their heart rate, etc. And one of the main problem that we faced, another main problem that is faced in this pandemic, that was not so, that is safe disposal of huge amount of biomedical waste. Now we cannot predict earlier that that amount of biomedical waste, especially the disposable masks, gloves, PPE, that was generated from individual hospitals, they need safe disposal. So that was another our challenge that we faced. And during our in the tertiary level, we have faced some post-COVID complications also. What we call them as long COVID. People usually continue to suffer from various problems, starting from tiredness, fatigue, chronic cough, as well as some difficulty in concentrating, etc. And another most important problem that we faced just after COVID outbreak, that is mucormycosis, which is a serious but rare fungal infection caused by a group of molds called mycomycetes. And usually corticosteroids were blamed, especially because they suppress immunity, and COVID patients have already suppressed immunity, especially the diabetic patients. Diabetic patients with suppressed immunity, when they are treated with corticosteroid, they become more vulnerable to suffer from mucormycosis. And this long COVID was one of the serious problems that we had to face during this time. And the another thing I should say, that already Sir has already spoken about the social and economic impact that is quite new.
Somebody has
The
kept his
pandemic, the pandemic has resulted in severe social and economic disruption around the world, including the largest global recession since Great Depression in 1930s. So it has led to widespread supply of shortages exacerbated by panic buying. The person who usually go for market for a single time a day, he used to visit market twice or thrice a day. Panic, agriculture disruption and food shortages. Numerous educational institutions and public areas have been partially or fully closed, and many events have been cancelled and postponed. And the most important thing that I should remember, I have forgotten to tell, that one of the most important thing that created that, we can say, fear as well as panic among the public is misinformation, which has been circulated in social media and mass media, as well as political tensions, which has been exacerbated. And the pandemic has also raised issues of racial and geographical distribution, health equity and balance. And India's GDP,
Please mute yourselves. There are several noises coming. Please mute yourself. Please mute. Okay, please, sir, continue. Kunal, sir.
yes. Can you hear?
Yes, yes.
So India's GDP by International Monetary Fund has come down to 1.9% from 5.8%. And the factors of major economic impact was labor mobility, lack of working hours, interruption in global supply chain, less consumption, tourism, and less demand in the community market at the global level. And individually, people had to pay huge hospital bills. Out-of-pocket expenses rose high after getting admitted in ICU with moderate to severe disease. And again, that problem is coming. I cannot change the slide. Next. Hang on. And the main thing is that the pandemic has had many impacts of global health beyond those caused by COVID-19 disease itself. We have some, you can say, positive effects of this pandemic. And this pandemic has led to reduction of hospital visits for other reasons. There has been 35% fewer hospital visits from heart attack. There was decrease in gastroenteric diseases like diarrhea due to some increased awareness linked to improved hand hygiene. And there was some decrease in the sexually transmitted diseases in HIV, etc. And the most important impact was on environmental health, and with improvement of air pollution index, decrease in air and water pollution, and we have got less transmission of influenza and tuberculosis because of our improved respiratory hygiene. So pandemic has taught us that global problem requires global solution, and international cooperation is needed. We have discovered work from home, study from home, shop from home, avoidance to visit to malls, markets, and crowded places, e-commerce portals witness record traffic. And India has attempted to broaden its research facilities and a shift towards testing mass population as recommended by medical experts in India and worldwide. So according to Soumya Swaminathan, before I end, I must say that maybe India is entering into some kind of stage of endemicity, where there is low level of transmission or moderate level of transmission going on, but nothing as severe as before. In other words, India is learning to live with the virus. So thank you all. I have tried to highlight some of the most important issues that we have faced during this pandemic. Surely there are many other issues, plenty of issues are there. And because of shortage of time, it is not possible to deal all these issues. But I tried to be as brief as possible. Thank you.
Thank you, sir. You can stop sharing now. I would like Sukomal sir to say the closing words.
Thank you, Dr. Kunal Mujumdar. Very deliberately, and he has done a vivid discussion regarding COVID-19, and also Dr. Jane Frederick, excellent speaker, international speaker. So today's evening we enriched, everybody of us enriched from this session. And what is about COVID, we have many things to say, and also at present, side by side, nothing to say. So I think there is no such further discussion regarding this. So thanks to all the participants, moderator, as well as our co-chairperson of this session, Dr. Paramita. So, and thanks everybody, especially Rivu, for conducting this session in a very coordinated manner. And this is really difficult. Our physical presentation is separate thing, and conducting this session in Zoom platform, this is also a very difficult thing. They are very sound about this technique. So thanks to all. And now we are closing this session today. Thanks again.
Thank you to all the speakers and the chairperson. So it has been a very long day, and for us and for Jean sir, it's probably the beginning of the day. So I wish you a very nice day today, Jean sir, and we shall keep in touch with you. We have been enlightened by all the speakers and all the chairpersons. So let's wrap up and let's say goodbye. Bye for today.
Bye.
Bye.
Thank you very much. It was a pleasure to join.
Thank you. Thank you.
Thank you.